Okay, Soumya, let's start.
Okay, sir. Good morning, everyone. Today I'll be presenting regarding congenital anomalous connections of coronaries. Mostly we'll focus on the connection on the pulmonary artery and anomalous connection on the aorta. So it's seen mostly in 1 to 5% of the total population, and it contains various spectrum of anomalies which require surgical correction for all. Broadly, we can divide into three categories. The first one is anomalies of origin and course, anomalies of intrinsic coronary arterial anatomy, and termination. In origin and course, we can further divide into 7 categories. The first one is the anomalous location of the ostium. It might be a high ostium, it might be a commissural ostium. The second one, origin of coronary artery from opposite sinus with 1 or 4 courses. The courses of coronary arteries can be interarterial, transeptal, retroaortic, and prepulmonic. Uh, the third category, where it originates from the pulmonary trunk, which is further subdivided into 4 categories. The type 1, where the LCA originates from the PA, type 2, where your RC originates from the PA, type 3, where the single sort originates, and type 4, where both the coronaries originate from the pulmonary artery. The next category is a single coronary artery. Then the fifth one is a presence of multiple ostias of a same coronary artery or both. Sixth one is origin of coronary artery from non-coronary sinus. The seventh one is a duplication of coronary arteries. In intrinsic arterial anatomies, they're divided into 3 parts, where there might be congenital ostial stenosis, or might be coronary artery ectasia or aneurysm, or maybe myocardial bridging. Then it can also terminate into different ways. The first one is a congenital coronary artery fistula. The second one is an extracardiac termination. The first anomalous connection of coronary artery was described by Brooks in Dublin in 1886. Next, we'll see the few surgical evolutions throughout the year. The earliest correction was done by W.J. Potts, who created an AP window to increase the oxygen saturation. The second was done by Little and colleagues who did PA banding. Paul and Robbins, they did pericardial podrage, which are now obsolete. In 1953, Mustard reported attempts to anastomose the turned down left common carotid artery to the anomalous left coronary artery system, which he detached from the pulmonary trunk together with a button of pulmonary trunk valve. In 1966, Cooley used CABG after closing the left ostium. The next thing which evolved was the translocation of the anomalous coronary artery from PA trunk to ascending aorta, which is the most preferred surgical correction nowadays. 1979, a tunnel was used within the PA trunk to connect to the ostium of the anomalous coronary artery to the aorta via an AP window, which was described by Takeuchi. ACG has also modified in one more way. He connected a free subclavian artery graft by sacrificing the limb to inside the PA trunk. So what is it? So what is called a alcapa? The whole of the left main coronary artery, or only the left anterior descending artery, or the left circumflex branch, which, if it connects anomalously to the proximal pulmonary trunk, it is called a alcapa. Embryologically, the coronaries they grow from the peritruncal area into the aorta with formation of single orifice for both left and right coronary artery. In our anomalous collection, it connects mostly to the sinus of Valsalva immediately above the left or the posterior cusp of the pulmonary trunk. The left main coronary artery usually divides within 5 to 6 mm of its origin. In this case, in an anomalous connection, the LV is always hypertrophied and greatly dilated, which mostly involves the apex. Also, diffuse LV fibrosis is present, which is mostly seen in infants because they are found to have recent and old lateral wall MIs. The fibrosis which is seen in this case is mostly subendocardial in mostly subendocardium layer. So whatever devitalized myocardium is seen in this case, they are called hibernating myocardium because once the reperfusion is done, they slowly can recover over the time once the blood flow is reestablished. Several features like extensive fibrosis and calcification of the subvalval apparatus or the papillary muscle mispositioning, they can cause mitral regurgitation in these cases. So how do they present? In infants, they have a bimodal presentation, mostly in cases less than 3 months, and in population more than 8 months. In infants, they present within a week of birth, and when no other abnormalities are there, they can show up after 2 months also, because in this period, because of high PA pressure, there is less coronary steel. So hence, the myocardial dysfunction is gradual. They can present with sarcomoral pallor and blueness, and the most evident sign is poor feeding and poor weight gain. The pattern of feeding is the infant takes first 2 to 3 ounces well, and then he stops. He has breathlessness and sweating. A baby may drop knees, arch back, and he can uncommonly cry or scream. Presumed causes angina. And so, in total, the infant presents in overt heart failure. Signs are very non-specific because we see non-specific systolic murmur at the base. We can find a pan-systolic apical murmur, which is by the MR component, and there might be a apical gallop rhythm because of failure. Continuous murmurs, they are not audible in infants. We can see a precordial lift with a gross cardiomegaly picture. Patient can have gross hepatomegaly, and on auscultation, we see a V's are rare. In adults, the presentation is often delayed to beyond 20 years. They are mostly asymptomatic, but if they present with all the symptoms of palpitation, dyspnea, and fatigue. The delayed presentation of adult can opt to high collateral formation or any intrinsic uh, situation which causes your good feeling of the left ventricle. On examination, we can find a non-specific systolic murmur from the MR component, and we can also find occasionally a continuous murmur over the upper left sternal edge due to retrograde flow from the coronary artery into the PA trunk. So how do we diagnose? The first and foremost thing will be ECG, where you will see evident anterolateral infarction changes. ST changes will be there. We can also see the left ventricle hypertrophy. Myocardial enzymes will be elevated, and on chest X-ray we will see signs of interstitial pulmonary edema. Echo, they will present with overt reduction in the LV function, mostly less than 20%. We can see the functional status of the mitral valve, which results in which mostly in a regurgitant component, and they will have high LV and diastolic pressure. A pulse Doppler in echo may identify a large right coronary artery and anomalous connection of the left coronary artery to PA trunk with retrograde flow in it. In this diagram, the first one, the echo shows LV in both systolic phase and diastolic phase, where you can see the apical four-chamber view. You can see the marked dilated LV cavity with severely reduced LV systolic function. The image B is an echo image of anomalous left main coronary artery or arising from the PA. The C, it shows in the color. The other investigation which can be done nowadays is a cardiac cath or or an angiogram. The right heart cath may show an increase in blood oxygenation at the PA level because of the coronary steel. Aortogram may see in the similar picture the abnormal origin of the coronary arteries, and the ventriculogram also show the retrograde flow from the coronaries to the PA. Natural history. They have a bimodal distribution. 0.26% of these patients with congenital heart disease undergoing cath. So the exact population, with exact number of population, the percentage is not certain in this case because they have a very high mortality, and even if they survive later, they are mostly asymptomatic. So the 0.26%, this percentage has gotten from the people who undergo CAT study, and then we found it. 65% of infant, they die within first year from the heart failure. In the right side graph, you can see that on the x-axis you have months, the time period, and the y-axis we have percent of the surviving population. Within the age of 2 months to 12 months, there is a rapid decline of the survival. Survival more than 1 year is due to presence of rich collaterals, or they will have a marked right coronary dominance, supplying both the right and left ventricle, septum, and lateral wall. They might die later from cardiomyopathies, mostly in the fourth decade, and in fifth decade, patient might die of sudden cardiac death. So when to operate as early as possible, and whom to operate? All patients diagnosed with alpha. We can rule out at the left main coronary atresia. So how to name it? The naming of alpha in relation to the pulmonary artery, where the surgeon stands on the non-facing sinus, looking towards the opposite great vessel. You can see in the diagram, in a normal case, the surgeon stands here, and the left side shows the origin of the left main, which is categorized as 2, and the right on the right coronary artery categorized as 1. So now we'll go for the technique of operation. The technique revolves around creating a 2-artery coronary system. It can be done by different methods. First is a translocation of the coronary artery, which is the most common technique preferred now. Second one is a tunnel operation or the Takeuchi repair. Third one is a subclavian left coronary artery anastomosis. Fourth one is a Yakub technique. Fifth one to do a grafting followed by closure of the ostium. The sixth one is a ligation of the coronary artery. Can be done in chronically ill patients or in emergencies. So general steps for all. Surgery best done with CPV at 18 to 28 degree cooling, and after sternotomy, pericardium is opened without touching the heart, because slightest touch to the heart may result into uh, fibrillation or VF or VT. Preferably, arterial cannulation of both aorta and pulmonary trunk in the initial time can be done with a bifurcated system to maximize the myocardial perfusion. Single venous cannulation, and immediately before commencing the pump, tourniquets are placed around the left and right pulmonary artery. Once the CPB is initiated, before the CPB is initiated, the tourniquet should be tightened, and then RSPB vent should be placed. Myocardial protection is very important because patient already has existing compromised state of myocardium, and there is a potential for inadequate delivery of cardioplegia solution to the left ventricle. Preferably, the plegia solution should be delivered to both aorta and PA, and once the plegia delivery is done, tourniquets can be removed and pulmonary trunk cannula can be removed. In other cases, few surgeons, they prefer single aortic cannulation and do not do pulmonary trunk cannulation. So, coronary reimplantation to ascending aorta. These diagrams represent aortic cannulation with a ghost representation, which is seen as a dotted line of the left main coronary artery originating from posterior pulmonary artery sinus. The immediately cardioplegia is started to prevent the coronary runoff and ischemia. The pulmonary artery is transected and the anomalous coronary is located. Careful excision of the coronary artery button is done. Before that, the ductus should be ligated and divided, which will help in fully mobilizing the pulmonary artery trunk and its branches. Excised portion of the ascending aorta in preparation for end-to side anastomosis between the coronary artery button and side of the aortic sac is done. Once the anastomosis is done, cross clamp is removed and successful alcapa transfer is done, and care is taken to prevent PA from compressing the coronary artery, which we can do by mobilization of the pulmonary trunk either into lateral side or to the anterior side, which we'll talk about it later. In some cases where it is not adequate, the length is not adequate, we can do extension of the coronary artery. So in figure A, pulmonary trunk is transected above the level of pulmonary valve. A sleeve of PA artery posterior wall is excised along with the left coronary orifice, and partially excised wall is continuity in origin of the left coronary artery. In figure B, we can see both the edges are there. Upper and lower edge of this pulmonary flap, they are sewn together using a 7O or 6O proline. And it is formed in a tube-shaped autologous graft, which has an internal diameter of around 3 to 4 mm, and it continues as the left coronary. In figure C, you can see the graft is sutured end to side fashion into the left posterior wall of ascending aorta with a use of 6O or 7O suture. And the defect of the PA is repaired with a fresh autologous pericardial patch. The third one we'll talk about is a tunnel operation or Takeuchi repair. This tunnel operation is done mostly in infants. In figure A, you can see after commencing of the CPV, the initial small transverse pulmonary aortotomy is done to confirm the unfavorable position of the coronary artery where it is located. The flap is extended to develop a anterior pulmonary arterial flap. It is based on the right lateral aspect of the pulmonary trunk. The dotted line indicates where to give the incision both on aorta and on the PA. In figure B, you will see the anterior pulmonary arterial flap is fully developed and the AP window anastomosis is created using a 7O proline suture. During creation of the AP window, we should take consideration that we should not indirectly injure or distort the semilunar valve because of the tension. In figure C, you can see the AP window suture is completed and the tunnel is created. In figure D, the remaining defect in the anterior wall of the pulmonary trunk is now reconstructed with an appropriate patch, be it autologous pericardium or be it a pulmonary artery allograft or a PTFE graft using a 4 or 5 proline suture. The next we'll talk about the subclavian to coronary artery anastomosis. This is indicated where the coronary ostium is very far from the adjacent aorta. And the approach is through aortic and single venous cannulation. We do not pull in this case, and it is done on a beating heart without cross clamp. First of all, we have to dissect the arch fully to expose the subclavian artery, mobilize the PA fully, mobilize the branch PAs fully. Then the appropriate length is measured and the subclavian artery is dissected distally and ligated and divided. Coronary artery is identified, anomalous coronary artery is identified and mobilized with adequate coronary button tissues, and end-to-end anastomosis is done. Next, we'll talk about ligation of the coronary arteries. This is used only to stabilize critically ill patients before with patients, then we can plan for more formal procedures. So how is it done? Anterolateral left fourth intercostal incision is given. Pericardium is open in front of the phrenic nerve after mobilizing the thymus. Ligature is tied around the tip of the LA appendage to retract superiorly. Dissection of the anomalous coronary arteries. Then pulmonary trunk, and it is ligated close to the pulmonary trunk wall with single transfixing suture or a metal clip. Next, we will see how to repair anomalous coronary artery, which is originating not from the trunk, but from the right pulmonary artery. In this case, we have to see the anatomy properly. After aortic transection, P is mobilized fully and segmental resection of the right pulmonary artery is done where the alpha originates. Then the coronary artery is rotated 90-degree clockwise and it's sutured to the ascending aorta. RPA reconstruction is done by end-to-end anastomosis with pericardial augmentation, and aortic reconstruction is done by a single or double surgery. So what to do with the MR, which is mostly associated with it? It can be left because sometimes after reperfusion, it is reversible. But in some cases, if it is very severe, patient might need reoperations after a few years. In Takeuchi repair, few studies are commenced. The conduit is blocked in after 3 to 5 years. And in left subclavian coronary artery anastomosis, that also blocked in 3 to 5 years. Hence, now still the coronary artery translocation is the most preferred method of the surgical repair. In some cases, in tunneling, like in Takeuchi repair, there might be RVOT obstruction, which can be prevented by using the generous anterior pulmonary trunk patch. Next, we'll talk about the anomalous connections of a main coronary artery to the aorta, which focuses on either the left penis connects to the aorta in a site other than left coronary sinus or the sinutubular junction, which is identified by the ridge between sinus and ascending aorta, or a right coronary artery connects to a site other than right sinus or sinutubular junction. It can be associated with interarterial or intramural course of the coronary artery, and they might have ostial stenosis also. In an anomalous connection of left main coronary artery, what are the different varieties we see? It can have two ostials which are side by side in center of right sinus of valsalva, which is most common. It can be eccentrically placed. It can be high in the right sinus and close to the right to left commissure. Single large ostium may be present in a right sinus, which gives rise to both the coronaries. Ostial openings, they might be slit-like or angulated, or they might have intramural course. It may run anterior to the pulmonary artery through the floor of RVOT also. In an anomalous connection of right coronary artery, they are more common than the left. They might have a separate ostium in left sinus, or they can have a single ostium. How do they present and how do we diagnose? 99% they are asymptomatic, so their true prevalence is not known properly. But studies say they have 1 or 2 incidents per 1,000 live birth. Mostly they're present in their second or third decade. So why do we follow up with imaging to see the presence of single ostium or separate ostia, to see the exact position of the ostium within or near the sinus, presence of intramural force is there or not, and identification of the interarterial force, determine whether the caliber is less or not. So RCA from the left aortic sinus of valsalva. This range of 6 to 27% of all coronary abnormalities. The patient comes with might come with angina, mitral MI, or complaint of syncope, may come with an AV block characterized by, they might be happening because of slit-like and stenotic orifice within the left coronary sinus. It can be associated with intramural course of the artery. And the coronary ischemia, in this case, is seen because the ostium is narrowed during the exercise or hypertensive crisis. So mostly the presenting population is either a athlete or mostly they are athletes. The LV dysfunction during exhaustion owing to aortic root and PA enlargement in this case. So how do we approach? First of all, same aortomyocardial cannulation is done. LV vent is placed, antegrade retrograde cardioplegia is given, and aortic transection or near transection is done to see the course of the coronary artery. Then the coronary orifice is measured by graduated dilators and they're recorded. Then a required dilator is advanced to see the intramural course of the RCA. Unroofing of the intramural part of RCA is done, where the trace come to the mind, measure 10 times, cut once. Tacking sutures are placed at the neo orifice of the RCA in the right coronary cusp. And hence, we separate the ostium of the right and the left coronary. Next is the left coronary artery from right aortic sinus of valsalva, which is the most serious anomaly and most common cause of sudden cardiac death associated with it. So, left coronary artery originating from the right aortic sinus in another condition is which is caused by acute angulation of the left main coronary artery as it arises from the right coronary sinus with a long course to the bifurcation, which you can see in the diagram. In this case, we do a side-to-side anastomosis between coronary artery and aortic wall and complete the anastomosis with continuation of the left coronary artery to bifurcation. Next, we will see translocation of the pulmonary trunk for single coronary ostium without an intramural component. In this case, the pulmonary trunk is carefully dissected of its bifurcation. Patch augmentation of the RPA beyond the bifurcation is critical to prevent RPA stenosis. Left pulmonary artery is opened towards hilum. Then the trunk is translocated towards left hilum and it is re-anastomosed. Complete translocation of the trunk towards the left hilum to create additional space between the PA and aorta. It is done in case of single ostium. This is the aortopulmonary. It is the anterior translocation of the pulmonary artery. In figure of A, you can see anomalous connection from the right coronary artery with single origin and normal proximal course. In figure B, you can see both branch PAs are fully mobilized and the RPA is transected and moved to the anterior to the aorta. In figure C, you can see right pulmonary artery is reattached and a pericardial patch is added as necessary, which moves the pulmonary trunk both anteriorly and leftwards, relieving compression of the interarterial portion of the anomaly artery. So to summarize, how do we proceed with the management? We'll see the osteal status. It might be separate or might be single. In a separate ostia, if it doesn't have an intramural course, we can do coronary artery implantation. If it has intramural course, it might be above or near the sinotubular junction or below the sinotubular junction. If it is above, then we do the unroofing of the coronary artery, which was described earlier. Or if it is below the sinotubular junction, we might do fenestration. Then a single ostial status, it can have intramural course or it doesn't have intramural course. Intramural course is as described. It doesn't have intramural course. If the RCA originates from the left coronary sinus, we do a lateral pulmonary trunk translocation. If the left coronary artery originates from the right coronary sinus, we do an anterior pulmonary trunk translocation. Then we'll discuss three articles regarding case reports, how the case presented and how the decision was taken. The first article is from Journal of American College of Cardiology, which describes with the anomalous origin of coronary artery when to operate. So a 34-year-old female, she underwent CT scan for 2 weeks of chest pain and mere syncopal events, demonstrating the anomalous right coronary artery origin from left coronary cusp with intramural proximal 1 centimeter and interarterial course. She was discharged and outpatient treadmill stress echo was done, which did not reveal any inducible myocardial ischemia. Cardiac cath with coronary unroofing and reimplantation of right coronary artery was later performed due to persistent symptoms. Even though the stress testing did not show inducible myocardial ischemia, surgical repair of the RCA was performed due to persistent symptom and intramural course. She did not experience any kind of symptom before that. So what we conclude in this, that stress testing has very high false positive and false negative rate, which range up to 38 to 66% and should not be used to guide the management in these patients. So in asymptomatic patients, they can be managed medically or conservative medical management can be done. But in cases where symptom is seen, they definitely need surgical repair to prevent sudden cardiac death. Second full text article is from Journal of American College of Cardiology. Incidental finding of anomalous origin of right coronary artery with slit ostium after multifocal atrial tachycardia induced end stemming is seen. The case goes like a 66-year-old male with past history of COPD, hypertension, and dyslipidemia presented with chest pain. The chest pain described as retrosternal, oppressive, and very high in severity, which lasted for 30 minutes. ECG showed multifocal atrial tachycardia with infralateral ST changes. Cardiac troponin were increased, and patient underwent left heart cath, which showed clean coronaries but slit anterior origin of right coronary artery, which was limiting guidewire passage. A coronary CT angiogram confirmed the anomalous origin with interarterial course and a slit-like caliber at its origin, suggesting an aortic intramural course. So what we conclude here, the slit-like origin of the RCA is an uncommon mechanism which may cause signs of demand ischemia during tachycardia. And coronary CT angiogram is a gold standard for diagnosing the coronary anomalies, and management decisions requires as a multidisciplinary collaboration. Optimal treatment depend on the anatomy and clinical context. Here, rate control is indicated to mitigate the risk of recurrent demand ischemias, and close follow-up is recommended for complex coronary artery anomalies, which he might be a surgical candidate later. The third case report is from same journal, an uncommon encounter anomalous origin of the left coronary artery from the pulmonary artery presenting with acute coronary syndrome and complete heart block. This is with a 81-year-old female with persistent atrial fibrillation and alcapa presented to the emergency with chest pain. She had previous medical records in 1988 where she presented with syncope and ventricular ectopies and diagnosed earlier, which the anomalous coronary artery filling from the right to left collaterals with large and ectatic coronaries. At the time, she underwent surgical correction with excision of the left coronary artery from the pulmonary artery and reimplanted. In the emergency, her vitals were heart rate of 42 and BP was 86/40. Her mental status progressively deteriorated, and ECG showed a complete heart block with underlying atrial fibrillation. Troponin was high in that case. Patient received 2 doses of atropine and transcutaneous pacing for a heart block. Emergency left heart cath was done, which revealed a calcified aneurysmal left anterior descending artery with a complete occlusion of the mid-left circumflex artery. She was supported with temporary transvenous pacing. Then PTC was done on the LCX and her complete heart block was deemed likely due to transient ischemia of the AV node. She did not require further pacing support and discharged home with optimal ACS management. So what we conclude, only 10 to 15% of Alcapa patients survive in adulthood. A study revealed that adult type Alcapa patients, they have a higher risk of major adverse cardiac events, including arrhythmias and cardiac death, compared to infant type Alcapa, as chronic myocardial ischemia cause irreversible ventricular remodeling as compared to contrast to infant type Alcapa, where it is reversible and that are so this case raises awareness in the association with Alcapa ACS is complete. Thank you, sir.
Thank you, Soumya. It was a crisp presentation. Unfortunately, I